Okay, why don't you start, Janene?
Oh, I get to start.
Yeah.
So Janene Fuerch, you heard a little bit about the background, but I'm a neonatologist, not a cardiologist, at Stanford Children's, and I also help run the Biodesign Innovation Fellowship. Go Biodesign alums, I know there's a lot of you out there. And then I also lead a group called Impact One, which is focused exclusively on pediatric and maternal health innovation as a really underserved area, but something that my patients desperately need.
Great. I'm Evan Zahn. I'm at the tail end of a very long and really fun career, which really started out doing interventional procedures on babies and kids, but as our babies and kids had improved survival, now about 60% of my practice is doing intervention on adults who were born with congenital heart disease, a growing population. Maybe we'll get into that a little bit. I am, when I say toward the end, in December, I'm going to stop practicing clinical medicine, devote my full time to device development for the pediatric space, and Mike and Linda have been kind enough to also ask me to chip in with this brilliant foundation that they have formed. So it's a real pleasure to be here.
Thank you. And I don't know that I need to do an introduction. I think I know so many people in the audience, but you know, I've had my career was started as a chemical engineer in Union Carbide and discovered medical technology in 1979, joined Baxter, and really grew up there for 20 years, had a chance to operate in a pretty cool meritocracy where if you got something done, they gave you more to do, and I really grew up. And then had the chance to really do my dream job, which was to lead Edwards, and that was from the time we spun out of Baxter in April of 2000 till 23, 24. And now completely turned our attention to our foundation. So we can end up talking about that, but we'll just have a conversation about all this. Yeah.
Well, you spent your whole life really focusing on adult cardiology, which you've made tremendous improvements, and no one needs to tell the room this, but it's always curious for me as a pediatrician, why did you decide to focus on congenital heart disease now?
Yeah, so it's a good question. First of all, I'm a believer in focus. You know, if you're going to do something, focus on something that you can be excellent at, maybe like the best in the world at, and don't try and just dabble in everything, because I don't believe that everybody can be good at everything. And so that was a little bit of the challenge at the beginning of Edwards was, you know, who were we and where were you going to go? We actually called ourselves a late stage cardiovascular company and when the company was born, which was kind of tragic. You think about it, we're there for you at the last minute, right? But over time, we really tripped over something that was in our history that really we believed deserved attention. That was structural heart disease, and that became our focus. But you know, along the way, there were these people who were born with heart defects. And talk about a structural heart disease, that's a structural heart disease, but they were relatively small compared to the adult population. And when you're a publicly traded company or anybody that's trying to be successful, you focus where the big opportunities are. And there were big opportunities in adult cardiovascular medicine to make gigantic change. And so it was hard to focus on everything. And so we just didn't put much energy into congenital heart disease. And our phone would ring. Every once in a while, a doc would call and they'd say, okay, you know, sometimes they get to me or sometimes they get to somebody in R&D or somewhere else in the organization. I've got a patient, I'm going to do him on Monday or I'm going to do him tomorrow, and I'm thinking of using one of your valves. Will it work for this? And, you know, our people, we'd start sweating bullets because it hadn't been tested for it and so forth. It's like, okay, we can run some tests overnight and try and give them a feel. But
that was in a pediatric patient?
They were in pediatric patients. And, you know, it was life and death kind of situation for these kids. But, you know, if you were to ask our lawyers, they would say, you know, if we do this, and as a matter of fact, if we send somebody to support the case, then we'll be complicit and we'll be part of this potential failure. So they would talk you onto it. If you talk to anybody in finance, it's kind of like, so how big is this opportunity? Oh, it's really small. So there were just no good reasons to get fully vested, but we would constantly try and help where we could, just because it was the right thing to do.
Yeah.
But I had always said to myself, boy, after Edwards, this would be a group that would be nice to focus on. And, I feel so fortunate in my life here to have had some success and to say, okay, I've learned some things and have some resources and have some friends. What if we were to really go after and try and tackle congenital heart defects? In my view, it's dramatically underinvested in.
Yes.
And without investment and innovation, it's going nowhere. What the docs do in that space, and we've got a couple of you are here to talk about that, is incredible. But rather than me do more talking, Evan, why don't you talk about what it's like? You've been a practicing physician, treating kids for 3-4 decades now. How's it look from where you stood?
Yeah, before I get too dark, I've actually gotten to live through in my career sort of this golden age in congenital heart disease. When I was a fellow, I was telling some of the young people yesterday, one of the things we were taught was how to talk to a family, to tell them with specific lesions, to take them home and let them die. That was part of my training, because 100% of that lesion didn't survive. This is the late 80s, early 90s. That doesn't happen anymore. Fellows don't have to get trained in that, because the overwhelming majority of our patients, at least in the United States, survive. Now, the cost of that survival may be steep: multiple open heart surgeries, multiple interventional catheterizations, lots of medicine. Maybe not the greatest quality of life, but survival has made a remarkable improvement in the last 3 decades. What's been frustrating for the last 3 decades is the lack of ability to truly make giant leaps like we've seen today in our adult colleagues, in heart failure, in transcatheter valve therapy, in EP, so on and so forth. And the congenital community lags significantly behind that, but it's not for lack of ideas. Let me tell this audience a few facts that you may not know. So if you go to ChatGPT, I know the young guys are going to be on this right away. If you go to ChatGPT right now and you say, what was the first cardiovascular transcatheter intervention? It's going to say in 1977, Andrews Grunzig, a genius, did the first coronary intervention. What it doesn't tell you is 11 years before that, Bill Rashkin did the first balloon atrial septostomy, which saved thousands, tens of thousands of babies. If you go and say, well, what was the first transcatheter heart valve put in? It's going to say in 2002, Hélène Crébier put in the first transcatheter aortic valve. It's not going to tell you that 2 years before that, Philip Bonhoeffer put in the first transcatheter pulmonary valve. My point is that the innovation in the congenital heart space has been remarkable. But what hasn't been there, as Michael alluded to, is the investment, both from academia, from national funding, from industry, and that has really hurt us. Part of, I think, what it says up there is that I'm the medical director for a small startup, Renata. Renata makes a stent specifically for newborn babies. This is 2025. That was the first stent ever approved for a newborn baby. So what have I been doing since 1989? Putting in off-label stents that I cut in pieces, remount with my hands on balloons, and that's typical of what we do in congenital. So I would say the frustration has been, we all love our children, but the brain power is there, the innovative spirit is there, the ideas are there. What hasn't been there is the ability to truly advance this field, which is why I'm so excited that somebody like Mike Mussalem has gotten behind this.
I would even just say, we're doing that for literally our most vulnerable patients.
What? Sorry.
We're MacGyvering things for our most vulnerable patients.
Yeah.
It's insane.
Yeah, it's insane, and it's almost become a point of pride, which is wrong in our field. Like, I can make this out of this, but it's ridiculous because we don't have the right tools. And just to put it in perspective for everybody, everybody should know this. If you remember nothing else, congenital heart disease is the more birth defect. 40,000 babies a year in the U.S. To put that in perspective, that's 3 times more than all childhood cancers. It's about 15 times more than cystic fibrosis. But people just don't understand the prevalence of this disease, and the death, as of 2025, from congenital heart disease in our country significantly outweighs the death rate of all childhood cancers, and we're just not putting the money into the space.
Yeah, probably a good way to think about that is, some of it is going to take a scientific breakthrough, but there's many things that we could do to make tools for those that treat congenital defects that are absolutely out there and available if we just had the spending and the commitment to get it done. But the math hasn't made sense in the past, and that's a little bit of where we're going to step in. But Janene, why don't you talk a little bit about what you're doing? So you're at the pioneering edge of a lot of bright ideas in this space and more. So why don't you tell the group a little bit about what you're doing?
I feel like I want all the people who are running pediatric medical device companies to stand up, because I know there's some of you here. And so stand up. I see you. Go ahead. I wasn't going to do this, but I'm going to do this. You guys, there's these people. And they're here. Henry's over there. Talk to them. So when you say these companies don't exist, they do. They really do. And there are innovators that are fighting to get this done every day, but it's not easy. And I guess my wish for everyone is that when you hear the word pediatrics, just stay and listen a little longer. We know that everyone just wants to turn away. The moment you hear pediatrics, it's too small of a market. There's no money in it. There's no ROI. But actually, it's not. The money does work in some ways if you do it in a streamlined, smart way. Not just the way that we've done adult cardiovascular for years, but you can make it happen. You can use philanthropy to get to sustainability. You can stay inside an academic institution longer. You can do a lot of different things. There's a lot of grants out there to get you to the point where you've de-risked enough that you can be interesting to impact investors, other investors, maybe people who want to turn up the impact dial and turn down the ROI dial just a little. I didn't say turn it off. It's there. But we have to be willing as a community to do that. And I think we really need to look inside ourselves and say, what do we want the future to be? Do we want it to be one where we are supporting our most vulnerable children? Or do we keep wanting to spend a lot of money in the last 30 days or towards the end of life? Because you can transform lifetimes, and we can do this. And there's people out there that are doing it. So my hope is that everyone supports them, because we're actually supporting them. So as part of Impact One,
Would you tell people what that is?
Yeah, I definitely need to. So it's at Stanford Biodesign, and it's our pediatric maternal arm. And the reason I had those companies stand up is because most of them, I can't see all of you because these lights are incredibly bright, but most of you we actually support. So what we do is we incubate our own companies. I have a bunch of fellows, some of which are here today, where we go out, we find unmet needs in a variety of pediatric spaces, but certainly congenital heart disease is included in that. We then go and develop technologies and then spin them out and get them out to patients. And then we also help a bunch of companies, usually somewhere between 40 to 60 a year, anywhere in the world. Any of you can send them to me. We'd be happy to assist them and help them. There's no catch. We just literally help them. Think about their strategy, think about their need, connect them to KOLs, connect them to reimbursement consultants, et cetera. Or we have some philanthropic dollars that we're able to give away as well. And so we've done that, usually 40 to 60 a year. We've done it for over 250 companies around the world on every continent, except for, of course, Antarctica. And then we advocate for policy change too. So we're trying to come up with data and evidence to really move the incentive needle. We know that needs to change on a global level, and always need partners to do any of this work. So yeah, if you just elevate here, I've been on a learning journey. I thought I understood a little bit about congenital heart defects, but the more that I've gotten into it, the more I feel like I need to learn more. We talk about it as if it's a pediatric issue, right? And often, a child's not going to survive a day, let alone a week or a month or a year without intervention. But in many cases, we're able to, through great hands, save folks, and they're able to live into adulthood. And there's a whole field called adult congenital heart defect that really needs to be developed. It's relatively raw. What the parents of kids will tell you is, it's a nightmare. When my kid turned 18 and I got turned over to adult practitioners, they just didn't understand,
you know, the same thing. They're used to looking at these adult diseases and not these heart defects. And so there's been a lot of learning that's gone on. The thing that's been so wonderful from my perspective is I just keep running into people that are ready to help. And like these two folks here, keep bumping into people at every turn that says, yeah, let's do this, let's make a difference. And so a lot of people have their heart in the right place. And as big of an issue as it is in the US, it can be pretty good in some of the biggest, best centers that have experience and see a lot of disease, but there's a big drop off. Matter of fact, why don't you talk about that a little bit, Evan? Just with the differences in the US and then contrast it to outside the US.
Yeah, happy to. I just want to say, just to jump on what you said though before that, Mike, you know, having been around this for almost 4 decades, the milieu has never been better actually for actually accomplishing some of what we want to do, meaning that we for decades we used as an excuse, oh, the regulatory process, it's grueling, they hold us to the same standards as adult trials, but we don't have the same number of patients or the money. The FDA has become a willing, active, true partner in the congenital space, which has eased the pathway remarkably to device development in this space, and not to mention the cost. They've just gotten fantastic. And I think more and more of us are starting to look at, there's a real economic argument, a national economic argument when you look at some of the dollars, huge dollars, we're talking in the billions and trillions of dollars over the course of a lifetime of a group of patients with complex congenital heart disease and what that costs our economy and their family's economy and their family's contribution to loss of income. Those numbers really start to add up, and I think we can come up and are coming up, and Mike's contributing to this, to a real economic argument while it makes a lot of sense to invest in this space. In terms of sort of OUS, many of us in our field, myself included, we go on missions, terrible name, but that's what we do. We go on trips to places like East Africa and remote parts of South America and et cetera. And for any of the problems we think we have in the US, you know, that's just magnified, you know, 1,000-fold when you leave the country. I mean, in 2025, there are scores of children not surviving from simple heart defects, stuff that takes us a half hour in the cath lab. Technology we've had on the shelves for 25 years. That is life-saving for these babies and these kids, but they simply don't have access. They're from resource-poor countries, and it's a large number because the incidence of congenital heart disease turns out to be the #1 birth defect globally. So there's a lot of kids out there just not having access to care.
Yeah, so as we try and think about this, it's a target-rich environment, as you might imagine, right? You can tell just by listening to this. And it's, the thought process has gone something like this. We really haven't announced the initiative officially yet. That's still coming. We want to make sure that we're well organized first. But the idea of trying to jumpstart some things with philanthropy, but create a sustainable system that's going to work when the philanthropy is gone, is really what the goal is. And so it's like, okay, so what can we do to change the math? So how do we get people to take and embrace this as a good investment? And whether you're a big company or a venture capital and so forth, the folks with the sharp pencils that are saying, it just doesn't work, it doesn't pencil out, and I get that very much. But so if we had better diagnostics and we recognized more of the condition in the womb than we do today, would the numbers go up? Could we take the risk out of projects by being an early partner along the way? Could we take the time out of projects by creating a clinical trial network in which you could gather lots of data in a hurry compared to what you do today, and go down the list of possible opportunities for us to change the math at the way people look at this. And so we're trying to really open our minds and take advantage of smart partners and smart thinking to say, what can we do to make a difference?
Yeah, I think also around the pediatric world, it's interesting. There's incredible collaboration, like you mentioned, but people are really interested in this. We really want to help our patients, as everyone does, but there is desire and like looking at this MacGyvering, looking at the fact that we don't have the tools we need for so long, we're really hungry for change. So you'll often find partners that are very willing to work with you. And the other thing is it might be a small market, but there's not very much competition in it. And there's certainly a lot of competition in your adult markets, and there's not a lot of competition. So you can own the market a little more easily. So look at the numbers that way too, not just the absolute, but the value that you're actually providing as well.
Yeah, just to jump on that, I think there's very much a feeling, again, just with a perspective of a few decades, that, okay, we've gotten from here, which is pretty impressive over 30 years. But I think there's also very much a feeling among our community that this is kind of as far as we can go without tremendous technological advances across the board in heart failure, in minimally invasive therapies, and ways to extra circulatory support for children. And in many cases, it's not a huge technological leap. We can take many of the things that some of our brilliant adult colleagues, I've heard a bunch of them this morning, and as a pediatric interventionist, I sit there and I go, all we need to do is make that a little smaller, and that's a game changer. So there are opportunities out there that are relatively low-hanging fruit, and I really think for the next generation to sort of make the next jump in congenital heart disease, really provide these kids with less what I call cumulative trauma over the course of their lifetime, cumulative medical trauma. Well, we can get there, and I think you can see it in this room. The technology's there. We have to figure out a way to adapt that to our particular environment.
I think there's the making it smaller, which works for some patients. But I would also encourage you to look at the specific diseases that we have and the specific disease states, because a lot of times what I see in my world is there's things developed for the 70-kilo male, and you're making it smaller to fit my 23-week, 500-gram neonate. It doesn't always work. Sure. Because sometimes they need very specific things, like they have umbilical lines as opposed to, PICC lines, which they eventually do have. But there's some very specific things, so I would encourage you to look at those areas of low-hanging fruit too. Yeah,
one of the things that's kind of interesting that we learned, and we learned this through interviewing patients and interviewing patients' families in particular. When you talk to some of these heart moms and so forth, you really get the story. And oh my gosh, tough existence, because if you have a pretty severe defect, you're going to go through multiple surgeries, because the surgery that gets done on the child gets outgrown. And so second, third, fourth, and it's not unusual for there to be 5 and even 10 open heart surgeries for these folks. And what that does to that child, not just physically, but emotionally and mentally, and for the young woman with the zipper down her chest and so forth, that's a tough existence. And just living with the uncertainty, because they turn to their doc and say, okay, what's my future like? And it's hard to give them certainty, and some of the answers aren't necessarily only the technology. Some of the answers are going to be different. So, for example, there's a group in Boston that's studying the importance of exercise. And one of you guys could talk about this a little bit, but it's, let's say it's cautiously administered today. And so therefore, a lot of these folks that have gone through surgeries are told, be careful. Don't exercise. It could be dangerous for you. And the consequences of that turn out to be worse than if we could take them through some kind of supervised exercise. So there's all kinds of interesting opportunities for us to impact lives.
Yeah, going back to what Janene said, in a sense, yes, it's a smaller, but certainly not insignificant number of patients that we can influence. But when you look at an individual project or an individual, we find a lot of empty space. And we see that with so many things. I think the project you mentioned from Boston, some of those folks are here. It's so creative and so innovative, but it's only at one center. So I think the idea of being able to find things that work for these kids who will become adults, but we need them to be functional societal adults, people who work and contribute. And I think to get some of these ideas and scale them out, nationally and ultimately globally will make a profound difference. And one of the things we really hope to do with the foundation.
I want to go back to something you mentioned before too, is about regulatory. Well, the FDA funds part of Impact One, so they are very interested in pediatric medical devices. So they do put their money where their mouth is on that one. I have found the FDA to be actually quite wonderful to work with, and you don't pay application fees if you have a pediatric device. So remember that. There's pediatric device consortiums, there's money to get that we give out every year, and there is very specific incentives around that. Where we find a lot of struggle, and I definitely want to talk to Renata, because is getting reimbursement. And so we need some reform there as well, and understanding around that, which I think is going to be a challenge, but it's not on the technical, it's not on regulatory, it's reimbursement, so that we can then still be attractive and develop companies, projects, businesses that are attractive to typical VC funding.
Yeah, I mean, again, I think the milieu and where we are in time is kind of there. One of the things, as you mentioned, Renata, was the ability to talk to CMS and get NTAP, right? New device technology, additive payment. That's huge, because when you go to a hospital with a new device and say, boy, this is going to cost a little more than you thought it was going to be, and they blanch, but you have a cooperative partner in CMS saying, let us help you with that, because this is going to save a lot of babies. That makes a huge difference. And I think answers like that are out there. But what I've seen for the last 30 years is we kind of all give up a little too easy. Like, it's a small market and the regulatory and you can't get reimbursed. I don't actually think that's true. And I think there's a really positive economic argument to be made. And again, it's one of the things we really hope to be able to change with the foundation.
Yeah. I smile because adult devices wouldn't get paid for if you didn't make a sound economic argument. And so, I mean, we have this kind of experience. We know how to do those kind of things, to generate the data that you can put in front of CMS and say, this is a good deal for patients, for the American public. And we know how to do it, but it takes investment, and it takes some know-how to do that. And we can bring that level of sophistication to this space for sure. Why don't you talk a little bit about some of the work that's been done at Stanford Biodesign related to needs assessment?
Oh yeah, absolutely. So Ignacio's here in the front row. He's done a lot of that work, so we have to give him all the credit for that. But the Stanford Biodesign process, as I'm sure many of you know, I know Todd has spoken up here about it before, is a really needs-based approach to innovation. That's a repeatable process. So we focus very extensively on what is the true need, not just from what's the need from the doctor or what's the need from the insurer, but the need from everybody and who are all the stakeholders within the healthcare environment. We have gone through and done a real needs assessment for the last year around CHD, which I think will be a really great foundation to the foundation. And being able to say, and talking to all of our amazing cardiologists, support staff, et cetera, in many different institutions, not just Stanford, but all over the country, and truly trying to understand where is the hotbed, where's the real needs, not the needs that come up first, that someone says, I need this, but also many layers deeper than that, to observe, to look, to see, are they structural, are they actual physical devices that need to be put in place and they lend themselves more to that solution, or is it potentially a solution around looking into systems change and those types of things. So while we don't talk about solutions up front, you can kind of get an idea of what flavor of solution might be there, and so it really encompasses all of that and some really nice areas that will need to change and be evolved and worked on for years to come. Yeah,
it's exciting though, but we will definitely take a needs-based approach, and that'll be a fantastic foundation. Yeah. So Evan, you've spent a lot of time in this. You've traveled the world, you worked with lots of entrepreneurs and so forth in this space. You talk about there being sort of a positive vibe right now, and you think people are forward-leaning. You think that you even think our regulators are probably ready to participate in this. So you're not really quitting, are you?
He's joining your
No,
team,
Mike.
I thought.
It's funny that you're asking me that question. Yeah, I listen. It seems like, and I'm pretty sure it seems like we're at this sort of inflection point, and somebody today was talking about when life's trying to give you a message and you just got to listen to it. And I was already kind of feeling that from working closely with the FDA and doing a lot of traveling and speaking to people around the world that something's ready to change. And right when I was kind of thinking that, you and Linda decided to dedicate all of what you sort of bring to the table to congenital heart disease. And I think anybody involved in this space would agree, we've just never had that kind of force behind what we do. And it's powerful. And I think it could make a real change. One of the issues, we talked about this a little yesterday, is we're a field filled with well-meaning people, as is most of medicine, but particularly people who take care of children with heart disease. It's a really communal group of well-meaning people. But because the money hasn't been there, just to put it frankly, that means the organization hasn't been there. And there's a lot of well-meaning people in disparate directions running around, and there's no cohesiveness. And if nothing else, utilizing things like the Stanford biodesign approach and really getting analytical about this, from what I saw yesterday, we can truly put together some cohesiveness in this space and bring these sort of really well-meaning, really pretty brilliant minds together and make a truly positive change. So yeah, I'm gonna stop putting on gloves and lead, because that seems like something that's worth getting behind.
Yeah, so it's a fun opportunity, and if there's one thing that I think we all know and we all believe in, is it's gonna take a village. It's gonna take a strong alliance for a lot of partners to come together. And if we can do that, if we can align people, we went out and looked at congenital heart disease foundations, and there's already, I don't know, I think what's the number, 24 by last count, something like that. And most of them are parents of a child who went through it and was miraculously saved, and are building a tower in their hometown, so forth, so others could get the benefit. But they don't have the understanding that we have about how the system works. We have all this experience in seeing healthcare at its best and at its worst, and what kind of things kind of work and don't work. And if we can bring that know-how, and if we can get the like-minded people with good intentions and big brains and good hearts, if we can get them to come together, there's our opportunity to really make a difference. And so we're gonna do our best to create this alliance that comes together and truly tries to drive some profound change.
Thank you for that.
Yeah, one of the things Mike says that really resonates with me, and I hope it does with this audience when it comes to this, Mike says to us, we're not building a monument, we're building a movement. And that's what this will take. This will take a movement of aligned interests to get this, but it's doable, and we can make a huge, and more importantly, a lasting change, I think, in a field that's been pretty underserved.
We can keep going. If anybody has any questions, we certainly welcome that. But we don't need to stop either. If you were going to say other nice things about me,
no, I was good. That's all. That's really all I got, Mike.
I'll say nice things about you. No, but I mean, what an incredible opportunity for congenital heart disease, and that you and Linda are giving. It's incredible, right? I honestly think that we should applaud you, but if everyone will join in me. Because you didn't have to. Yeah. You didn't have to do this, but it's going to make a real impact.
Yeah, well, we haven't done anything yet, but we're going to.
That's right. Well, setting intention is the most important part, right?
Yeah, it is. It's where we start.
Yep. Hi. It was very interesting when I heard you talking about the support that we're getting from the regulatory bodies to be able to get these new technologies out for children. I don't know if you're aware of this, but there is a task force called the Pediatric Heart Valves Task Force, and it partners physicians, people from industry, as well as the FDA, to really look at ways in which we can expedite commercialization of pediatric products. So to your point, Evan, there is indeed a movement, and I see it in so many different ways. Thank you.
Yeah, sorry, go ahead, Mark.
Please, go ahead.
No, it's a great point, Christine, and I know you've been involved in that, and I think it's another example of, there are kind of several of those collaborations going on, and I think one of the functions the foundation can serve is to sort of centralize that. We have work going on with HPD, which is Harmonized by Doing, which is a collaborative between the FDA and the Japanese PMDA, their regulatory body, and that's a really good effort fighting to get pediatric devices available, not just in the United States, but in Japan. And yet all these things are sort of running separately rather than together. But I think it would be really powerful to be able to centralize and just bring more power to the table. But yeah, it's a good time. I know it sounds weird, especially from an interventional cardiologist. It's a good time to work with the FDA. That's just been my experience.
I tend to agree. I mean, everything that we hear from them, they really want to help. But what I end up hearing at the bottom line is they don't know how to help. And a little bit of this is on us to make the differences, like specifically. Now, really, what can make the difference here, right? And so I think they're all ears, and we need to give them that right balance because they're trying to protect the American public at the same time provide these new technologies to them. And so to help them get that balance right is something that is on us to figure out, right?
Yeah, I'll give you a great example. That's spot on. I'll give you a great example that there was a device made by an American company that makes us a lot of wonderful devices, but it wasn't available in America. It was OUS only for reasons, and it was made to close a hole in smallish children, but not babies. And a few of us went overseas at meetings and we saw this device and we said, oh my gosh, we've been trying to figure out how to do this in tiny premature babies who need it the most, but they're really little, like less than a kilogram. So we went to that.
By the way, how old is a child's heart when they are only a kilogram?
Yeah, like a grape-ish pea. So we went to the company, who's a great company, and it tried to make an argument for why we needed to bring that because while it was available in the US, they weren't treating the most vulnerable population, the premature population, but we would in the United States if we could get access to that device. And they went through the finance, it just didn't make any sense financially, and why would we do that? And we said to them, well, what about if we met with the FDA and we asked them, because they wanted to help. They had come to us saying, what can we do for you guys, which is strange. We said, well, we have this thing, and how realistic can we make this trial for this company? So the device I'm talking about is the Piccolo device, which has now been approved for a couple of years for treating Janene's premature babies. They required us to put in, my adult colleagues are going to love this, 15 patients less than 2 kilos.
Yep.
And if we could show safety and efficacy, but mostly safety, in 15 babies in the United States, we now do hundreds of these per day in the United States. That was the bar that they held us to because they really wanted to help. But like you said, Mike, they didn't know how to help until we approached them.
It's a great story.
Yeah.
So there we go.
That was fast.
Lightning fast.
But thank you all for this. This is amazing, and obviously it's great causes. I'm Clifford Kravitz. I'm a UCLA Biodesign AI Fellow. And Evan, you mentioned that there's that kind of inequity globally for things where we have it here within the cath lab, we've been doing it for ages, but pediatric patients are dying elsewhere. How do you see technology helping to alleviate that issue?
Yeah, I think it can play a huge role. One of the things that jumps to mind is 3D printing for sort of the lower income countries in multiple ways. Teaching. So I do a lot of work in East Africa, and most of the East African countries will have one congenital center. And what they will have done is sent out a surgeon to a more advanced country, gets his training, comes back, and people like me and other people come through a couple of times a year. But what that surgeon really needs is sort of continued mentorship. and consumables. Consumables is what hurts in the third world. They can build a $6 million cath lab, but keeping the catheters on the shelf is difficult. Those seem to me to be problems when rapid 3D prototyping and printing becomes really standard. That can be overcome with that. So modeling, physical models for young surgeons to practice complex techniques before they do them in patients. That's already been shown in our literature to improve outcomes in the Western world. There's no reason we can't adapt that along with virtual technology to have your surgical colleague in London walking you through that and doing the same thing you're doing. And then on the production end, I think printing out things that could be done cheaper than the traditional way of factory pulling out things might make a real difference. We have to find a way in the low-income countries to supply them with a regular supply of consumable goods. That is a big problem that I don't begin to have the answer to, but I think those of us who go on these mission trips, it's important we're there, but I think it's even more important that we bring supplies with us. But that's not a solution.
So I'll wrap up. Of course, if we had strategic companies spreading the technology around the world, it would kind of help too. But we'll try and tackle that one along the way. But thank you, everyone, for your interest. It's very meaningful to us. We're going to be diligently working on getting our act together and looking for some strong partnerships along the way. So thanks so much for your interest, and keep an eye on us. Thanks.
Thanks.